Hi, I'm Dr. Morgan. I'm a family nurse practitioner. Today, I'll be talking to Dr. Nancy Riley. She's a family nurse practitioner as well. And we will be discussing the DNP role, or the Doctorate of Nursing Practice role. Dr. Riley has recently completed her DNP. Congratulations, Dr. Riley.
Thank you. Thank you.
Welcome to the club. You've been one of my long-term mentor. I knew you back in nursing school in Jamaica. You were a senior, and we've remained in contact all these years. And I'm really, really proud of you in taking the step to achieving your DNP.
Thank you. Thank you so much. It's quite the journey.
It is. So I'm in Florida, and Dr. Riley is in Arizona.
Yes.
Oh, sorry, I'm not in Florida.
You're dual, so it's okay.
I'm in Texas. Okay, so we're talking today about the DNP role, and first we're nurses, registered nurses, and we advance our career to the master's degree level and up to the doctorate level. And it has been a journey. It takes many years of discipline, dedication to achieve the level of education that we have achieved. The public, though, don't really understand what a doctorate in nursing is. And we get a lot of feedback, some of them positive, some of them negative from patients, especially when the patient is not pleased, when they don't get what they want. That's a sore point right there. But for nurses, they do understand the role. Back in when I was in nurse practitioner school, I used to write a lot of papers, a lot of research. And one of the things that we were focused on at that time was Healthy People 2020. At the time, it was 2015, and we were trying to achieve the goal of Healthy People 2020. One of the objectives of the Healthy People 2020 was for healthcare industry to be optimized in order to provide comprehensive and quality healthcare to patients across the board by increasing the number of primary care providers in inpatient, outpatient setting, because there's been a long-term shortage of physician.
Right.
Physician retiring, the profession is very hard to get in, and it takes long for a doctor to be trained, 4 years of training, and then they have to go into residency. So it's not a quick turnover. And the healthcare industry suffer as a result of that. COVID didn't make it any better. So now we're still seeing that, seeing that shortage.
Yes.
As nurse practitioner, we play a vital role in the healthcare industry by providing primary care or inpatient care, whatever specialty we function at. And our role, really, we have a collaborative relationship with physicians, but in about 25 or so states, nurse practitioners have full practice authority where we can work without collaboration with a doctor. For instance, for me, I live in Texas. This is my home state, my primary state. I have 9 state licenses. The other 8 states I practice without any form of collaboration. So with that being said, Dr. Riley, I want to find out from you. I have a specific question that I have for you. And this question is, how do you see your role as a family nurse practitioner with a doctorate in nursing practice, fostering change or bringing something new to the profession?
Thank you, Dr. Morgan, for having me on your program today. I've been following your series, and I find them pretty interesting and different perspective with your guests that you have on whenever you make these presentations. And so thanks for having me. And then, as you mentioned, my name is Dr. Nancy Riley, and hail from Jamaica. That's our base, and we're here in the United States, and just been a nurse practitioner since 2015, but just recently in June, advanced to my doctorate. And, just reflecting on your question that you mentioned earlier on in your introduction, that the emphasis is really quality improvement. And, that's what the Doctor of Nursing kind of brings to the table as it relates to the profession. So during the course of our training, like I said, the emphasis is on quality. And so usually the nurse practitioner would be focused on an area that's passionate to him or her, and, delve some deeply into that area. I think for you, you did diabetes. I think that was your passion. And in my program, I looked at smoking, and I'm very passionate about that because of personal reasons as well. I had family members who were smokers, and I see all that impact their overall health. And so that was always something I'm passionate about in bringing to the table, to improve the quality of the patient experience and the patient outcome. As you mentioned, a lot of times there's confusion as to what is the role of the nurse practitioner, because, it stems from nursing. And so we're known as nurses, and we'll always be nurses. That's our base. We bring that to the table because nurses come with a wealth of knowledge and experience, when they come to that nurse practitioner table. And some of us do a master's level, in the nurse practitioner field. That's where most of us started out, and others go on straight into the Doctor of Nursing, or go for further training to be to obtain their doctorate in the profession. And so, like I said, quality. So when we think about quality, we want to improve the quality of the patient experience, the patient outcome. So we're not developing new research when we're doing this quality. We're looking at what's already there, the evidence that are out there, and then people are always doing research and, putting out new evidence to impact practice. And so for the nurse practitioner or at the doctorate level, we look at the evidence that are there. And so we see what is best practice. How can we improve? So to make it more personable, so in terms of smoking, so how do I improve my patient's experience to say, encourage them to stop smoking? Because just like any other addiction, smoking is not something easy to say you walk away from it and stop overnight. It's a constant battle that, the patient might go through and experience. And usually you don't want to approach it from a point where you come across as judgmental or preachy to the patient. So the idea is to engage the patient at each encounter. Based on the evidence, it shows that you really need to ask. And in a busy setting, like you mentioned, with us being short staff and all of that, sometimes it's not practical. You have to just focus on what the patient came for on that day. But the evidence suggests that really and truly at each encounter, because you never know when you might see this person again. So they might present and say, okay, I'm here today for just an ear infection. But, they might not come back for the ear, but they're a smoker. So you really, have to capture that moment to say, hey, we're going to address your smoking as well to see if you're ready to quit or even get some medication on the path or some suggestion for other support services that are there to support that effort. And so that's where the quality comes in, because you're not just looking at that specific thing that the patient might present for on a given day, but you broaden your scope. So whatever your passion is or area that you want the quality to be improved, whether it's be diabetes, okay, so they're just here today for a toenail infection, but they haven't presented for their diabetic exam in the past 3 or 4 months. So you have to capture that in the moment to ensure that the quality of that patient is improved in some way. So yeah, that's what the Doctor of Nursing kind of brings to the table. But a lot of time the patients are not aware of that, because they're used to the medical doctor being that person who provide that medical, diagnosis and care. So sometimes they're not too sure of what it is. And it's just more for us to educate patients and the wider public on these aspects of the Doctor of Nursing practice.
Thank you, Dr. Riley. I I've heard about several DNP projects and never thought of smoking as something that, you could address. And it is really, really a
Yes,
troublesome issue for
it
patients.
is.
So I'm
Mhm.
actually visualizing Dr. Nancy Riley smoke cessation practice, something
Yes,
to that effect. Yes, speak it into being,
definitely.
speak it into being, put it out there to the
Yeah,
universe, because a lot of people
definitely.
struggle with that.
Yes, it's
When
a
they
big
stop
issue.
when they stop smoking, they gain a lot of weight.
Yes, yes. And a lot of patients are resistant to that too. And also it's if another person in the home is a smoker, because a lot of time and especially patients who are overweight and are planning to do, say, bariatric surgery, one of the criteria is that they need to quit smoking before, they go into surgery, and some surgeon will not perform that surgery if they're still smoking. And even if you try to say, okay, you put them on a patch or some kind of oral therapy, sometimes that's not enough, because their partner or some other person in the home is a smoker. And if they're not on board to say they're going to walk this journey, it's really a challenge for the patient. And some of them, they really make conservative effort, but it's a challenge. It's a
It
challenge to quit, and it does impact other aspects of their health. So yeah.
definitely, it has been a challenge. As Jamaicans, Jamaican nurses, we don't really see professional smoking in Jamaica. So when I
That
came
was
to
an eye
America,
opener. That was a culture shock.
when I came to America, and there was like a smoke, an area for smoking, and
Yes. Oh,
people,
yes.
same doctors and nurses who were on the floor working, they go out to
Take a
take a
smoke
smoke.
break.
I was like so shocked. And then
Yeah.
now they have smoke-free campuses. They can't smoke in the hospital.
Yes.
And that
Yes.
is a
Yes.
problem. I've worked with a nurse since I came to the US, and like every 15 minutes she disappeared. She was
Mhm.
downstairs smoking. It
Yes.
affected the quality of care that she was
It
able to
does.
deliver to the patients.
It does. And it's, in essence, it's not to be judgmental even of that nurse too, because culturally it's an accepted norm, and they're introduced to it very early. And like I said, culturally it's not frowned upon for professionals to engage in that activity. So it's and just like any addiction, like I say, it's an addiction. So they have that need to do it. And so it's good that the workplace does facilitate it in some way, so that at least they'll be able to come and function at work, because we
You
probably
know,
would want to see what they look like if they're not able to. They'll
trust
probably crawl
me,
off a lot more.
my daughter and I, we went to this restaurant the other day, and we were eating in our car. We bought the food and we're eating in the car.
Mm-hmm.
And within that 30 minutes that we were there, the same staff who worked in the restaurant came out
Yeah.
like 3 times. So my daughter,
Yes.
to
Yes.
smoke, and while he was smoking, he was pacing and smoking. And my daughter said to me, "So how many hours did he work for the day?" Because most of the time he's outside
It
smoking.
is. So you see, it is a serious issue. We might not even realize or look at it, because you're looking at time lost there from work, even while you're at work.
Yes.
So like your daughter rightly visualize and notice, like, how much did you really put into the work during the time you're there, if half of your time is spent addressing this need that you have.
Yeah. So it's a well needed area that you're focusing on. So I'm expecting to see Dr. Riley setting up a smoke cessation practice, and not only just prescribing, but also providing therapy to patients who need it and help them quit that habit.
Yes.
So it was really, really eye opener for me. I just look at it as, oh, it's just a little bit of smoke. So
Yes.
I didn't realize.
It was during the old process of, doing the doctorate program that I kind of delve a little more into it. Like I said, I was more approaching it from a personal standpoint, but when I look at the research that are out there, it kind of helps you kind of hone it more to see how you can be effective for your patient and improve their quality of life. And like I said, the idea is at each encounter you have to address. So it's not to bombard the patient or, as I said, to belittle them or let them feel like, pressured, but just to open the question, do you smoke? A simple thing is ask them, do you smoke? And that's a part of the vital signs that we're doing every day. We say, do you smoke? And are you ready to quit smoking? Because sometimes just putting it out there, and then by also pointing the patient to available resources that are there, it can be very beneficial for the patient as well. So yeah,
that's
you
excellent.
have to capture that moment.
Yes, that's excellent. A lot of people don't understand with the Doctorate of Nursing Practice, when you go in, it's a lot of research based,
Yes,
a lot of writing, and each nurse practitioner is looking at an area in the profession that needs to be developed.
yes.
That is, the service is limited, we can do more, or things that people overlook, and then we bring that
Right.
table and develop that area and offer that service to patients.
Yes.
For me, I focus on diabetes because even though everybody know about diabetes and a lot of patients were going to the doctor for their diabetes, the population that I targeted was people who did not have insurance.
Okay, to the underserved.
People that didn't have insurance. And in America, sometimes they don't know that they can actually seek medical care if they don't have insurance.
Yes.
So I started working at a low-income clinic that was a nonprofit organization, and it was full every single day. These patients' diabetes was so bad.
Yes.
Their numbers were so high because they're not compliant, and they usually come in when they have the funds. If they don't have the funds, they don't come in.
Present, yes.
Everything was out of control. So I decided that I wanted to focus on that population. So when I opened my clinic, opened a nonprofit organization, and they started coming, it was the same thing.
Yes.
Now I'm having more resources. I'm getting medication that I can help them with to help them lose weight, help to bring down their A1C. But the problem that I run into, as soon as their A1C is better, they're gone.
Yes, because I think they're cured.
I think they're cured, and I educate them in the beginning, like, I'm gonna get it down.
Yes.
You need to still come as soon as it's better.
And I think, that's where the background in nursing is kind of helpful for us in our practice as well, because, we bring that empathy factor to the table. So it translates from the bedside to the office, where we still kind of bring that focus and just kind of always have that willingness to reach out to the patient and do more, community service and kind of, encourage them, because of course, you see that your numbers are better, you automatically assume that, yeah, I'm cured of this thing. And that where it comes back to the educating of our patient to say, hey, this is a chronic illness, and the numbers can change at any time. So you have to stay constantly vigilant on your practice. Yeah.
Yes, that is true. So this brings us to our next part of the discussion, where a lot of people look at nurse practitioners and they don't really understand our role. They'll try to figure out, are you a doctor? Are you the same thing as a doctor? You're using the title doctor, and they're confused. And doctors have their scope of practice. Nurse practitioners have their scope of practice. So every board of nursing in every state set those guidelines of practice, and we're trained and we practice within our scope and according to our education and training. So it's a different thing. So usually for doctors, there's a certain number of years that they train, and they go into residency. And then after residency, then they can practice independently. For nurses, it's different. We start off as registered nurse at the bedside. We train for like a 4-year program. Then we go back, we work, then we go back to school for another 2 years for nurse practitioner. and then we do another 2 years for doctorate. So it all adds up, even though it wasn't done at this one time. It
Yes.
adds up with years of experience and study. How would you, if a patient come up to you, Dr. Nancy, and say, hey, so you have a doctorate, how is your role different from the medical doctor role? How would you explain that to them?
Thanks for that question. So a very important question, and we do get that, quite a bit. And, as just even retracting as it relates to being a family nurse practitioner or a nurse practitioner versus a doctor of nursing practice nurse practitioner. And I always say it's really just aesthetics. Personally for me, it's aesthetic because my role really hasn't changed, since from what it was 5-7 years ago versus what it is today. I still see my patient, diagnose, prescribe, educate. So, okay, so to focus on your question itself, I wouldn't compare nurse practitioner and like a doctor of nurse practitioner to a medical doctor. I wouldn't compare them. There's no need to compare or contrast. We're trained, like you said, on 2 separate models. So, the nurse practitioner was trained with the nursing model, starting, with the nursing base, and it continues on. And the medical doctor was trained with a medical model. All right. In essence, we all practice the same. So like you mentioned, there are some states that are restrictive and there are others that are not. There are some states, like my state, we have full practice right. And like you mentioned, in your current state, you have that too. So we're not practicing under the umbrella of any medical doctor, okay? However, there are some insurance, like for Medicare, that we do require the co-signature of a medical doctor to sign some Medicare document, because that's a Medicare requirement. Okay, but in general, the nurse practitioner in most states practice independently, based on our training, like you mentioned, extensive training. And like I said, a lot of nurse practitioner, be it just a nurse practitioner or a doctor of nursing practice nurse practitioner, bring a lot of wealth of information to the table and experience at different level. There are nurse practitioners who did bedside nursing, and when they did bedside nursing, they did like med surge, orthopedic, neuro, they bring dermatology, they bring pediatric. So every discipline that you can think of, they bring it. Some of them are midwives when they enter the field of nurse practitioners. So it just depends on, the experience that they had as a nurse before they entered the actual nurse practitioner. So a lot of them come with a wealth of knowledge and experience to the table. As it relates to practice in terms of our medical practice, it's the same. We see patients, we assess them. Some of us work in acute setting. So acute care is where you just see somebody for that day, and you treat whatever complaint they present with for that day, okay? And you address that. And some of us practice in a primary setting where we address both acute situation and chronic situations. So it's the same as the medical doctor. The doctor of nursing, the NP, it's the same. We practice the same, we diagnose, we assess, we diagnose, we prescribe treatment, we do education. But like I said, I think, and it's probably a biased thinking, that with the nurse practitioner, you find that we bring that nursing model to the table, and it kind of bring more, I would say, empathy towards the patient. And then again, like I said, it could just be a biased thought of mine, right? But I think we bring that empathy factor, and patients will tell you all the time too. And of course, a lot of them love their medical doctors, and they'll not change them to come see you. They'll see you for an acute situation, but they'll go back to their main provider. But for the most part, you'll hear it that they kind of, because like I said, you kind of relate on a more personal level, I think, with the patient outside of the textbook directive.
That was an excellent explanation, Dr. Riley. Awesome. And while you were there talking, I said, okay, there's Dr. Riley, the professor. You're ready to teach now,
Well, like I said, I tell you, we all come with our different level. I have a master's in education, so we come with different umbrellas to the table.
You're ready now to teach. Gonna have to hook you up. Well, this is a awesome communication today, and I'm really, really proud of you to to hear how you present yourself, the level of work that you're doing, and providing this education to bring awareness to different roles and the
Yes.
role that we play as nurses, advanced practice nurses, DNP nurses, to the field of healthcare. It's really, really important.
I truly appreciate these topics that you're bringing forth. As you said, it kind of more awareness, because we do really need more nurse practitioner in the field, because especially where I practice, it's an underserved, I practice in an underserved community. It's in community health setting. And like you mentioned, a lot of time patients are not aware that these facilities are available and to give them care, even if they have little or no insurance, because with the company that I work with, we do get some federal funding. So we do have programs for patients who have little or no insurance, so they can come over and, they assign them, and they usually put them in categories, whether it's be A, B, C, or D, based on their income or no income. And so they get the care that they need. Nobody's ever turned away.
That is good, because what I find out is that when patients are able to utilize these services, it keeps them out of the emergency room, because a lot of patients were using the emergency room as their primary care.
Yes.
And what the emergency room physicians are doing now, I'm not sure if you notice that they're not discharging them with a prescription anymore. No prescription.
Oh, is that a new thing?
Yes, they treat you in the ER and they discharge you. You need to go follow up with your PCP.
With your primary.
They give them a prescription.
It's just maybe for 2 days or one.
They give them for a short amount of time. They used to give them like maybe like a month supply. What these patients do in Jamaican term, they pinch the medication, take it little by little, when they feel as if they need it, when they have that headache before they take it for their blood pressure. And when it's done, they return to emergency room instead of going to a primary care provider to get a long-term maintenance management of their condition.
And I know one of the concerns that a lot of nurses have too, in terms of pursuing higher education, in terms of, whether it's be their nurse practitioner or doctor of nurse practitioner, is the cost factor. And in a lot of ways, if you work for a federally approved facility, then you're eligible for like loan forgiveness. So those options are there as well, for nurses who want to advance themselves. And
yes, and also you're venturing into an area where you will also improve on your income.
Yes.
Life will change. You can never tell where it's gonna bring you.
Yes.
You never look at the cost for it, for education, to limit yourself in advancing your career.
Yeah.
For me, I didn't think I have a choice in becoming a nurse practitioner, because the 12-hour shift wasn't working out for me anymore. I had a small child who needed supervision after the school bus drops her off. And I was at work. Every time it was 3 o'clock, my heart was pounding.
Right.
I was like, I wonder, did she go inside and lock the door as I told her to? And I called that phone, and she didn't answer. Then I was calling the neighbor, did you see her downstairs? She's downstairs playing, even though I gave her strict instructions. So I said, you know what? If it continues like this, I'm gonna lose a child.
Yes.
Someday somebody.
Well, two of my main prompt behind pursuing that too was like, I hated working on weekends and holidays. I was like, this is one way I'm gonna get rid of this holiday working and weekend working. Yeah. So it really opened the option for you to kind of dictate your practice. Yes. Right.
Yes.
More
flexibility.
Yeah. So, you're available to be more free and kind of hone whatever you want to do with your time.
Yes, I will definitely bring you back on, Dr. Riley, because we have so much to talk about, and we'll be talking off the air as well.
Yes.
Really, really a refreshing conversation, and tune into my health talk. I was so excited to speak to Dr. Riley. I don't even think I did introduce myself, or this was health talk. with Dr. Morgan and Dr. Riley. We're both family nurse practitioners with doctorate in nursing practice, actually from the same university as well.
Yes, alma mater.
Yes.
Go you.
Yes, so it's really a pleasure speaking to you today, and we'll be talking again in the future. This was Health Talk. We spoke about the Doctorate of Nursing Practice role today as nurse practitioners. I hope you enjoyed. Please feel free to comment, and I'll see you next time in my discussion. Thank you, Dr. Riley.
You're welcome. Thanks for
Bye-bye.
having me.